an emergency, we'll talk about what is known as the intussusception. Okay, intussusception. So what I actually understand about intussusception, I know that it's also known as telescoping of the intestine. So it's just like intestines are actually like this. So one actually collapse into the other. Do you understand? So this can actually distort the blood supply. Like it can lead to some compression on some blood supply, and some parts of the intestines, the blood supply can be cut off, and you have all the story of tissues also getting to die off and all of that. Okay, so it's a pediatric surgical emergency. This is when a segment of the intestine, that's a proximal, is collapsing into the distal. Okay, so it can lead to obstruction, and of course blood vessels run in the wall of the intestine, so it could actually compromise the blood supply there. Okay, so epidemiology is a common cause of intestinal obstruction in infants and young children, and is usually dominant in the males, like it occurs more in males. So etiology sometimes is not known, so it says idiopathic. Sometimes it's caused by Meckel's diverticulum, intestinal polyps, lymphomas, Venous colon purpura, then post-viral lymphoid hyperplasia. Okay, that's the Peyer's patch getting so large. So clinical features, that's like a child having this intussusception, what would they be having? So colicky abdominal pain, they can be vomiting, bilous vomiting. Then when they pass out stool, the stool is mixed up with blood and mucus, so the stool will be red. They call that a red currant jelly type of stool. Now other signs is you have a palpable sausage shaped abdominal mass, lethargy and shock if it is advanced. The diagnosis is ultrasound, you use x-rays, okay, then contrast NMRs. So for management, you have to stabilize the patient with intravenous fluids, correct the electrolyte imbalance. Then, well, it's just all about ABCD of resuscitation. Then definitive treatment is surgery. Okay, then where they manually correct that abdomen going into another one. Then if you have dead tissues, if the patient is presenting late, you might have to cut, okay, then anastomose the viable components of the abdomen. So that's what we got for